Good afternoon, everyone. It's 12:10, so again, just to preserve your time, I will start, and the session will be recorded for anyone to get back to it later on. Okay. Good afternoon again, everyone. Thank you for giving us the time to do this presentation, and it's always good to connect with MediClinic team again. It's always good to see you all again. And hello, Dr. Muhammad. Welcome back. So again, for anyone, if anyone objects to this presentation recording, please let me know, because anyways, it's being recorded. So this presentation should not take much. You might see there's a lot of slides, but we will not dwell on all of them for a long time. For a beginning, my name is Laith Abu Dawood. I am the application and the product specialist in the Stago Dubai office. So we will be covering the Antitin A product that we were in discussion with you about. And for today's agenda, we have the following. So we will cover quickly Stago portfolio, our offer for anticoagulant monitoring. Then we will go over APTT versus antitin A. Why are we switching to antitin A, especially for unfractionated heparin? Or actually, it's only for unfractionated heparin in this case. Then we will go quickly over the product itself. What are its features? What's special about it? Then we will go over a quick overview for direct oral anticoagulants. Then we will go over again the product itself and its features in terms of direct oral anticoagulants monitoring, or specifically direct TNA inhibitors. So first, we will go over the portfolio. Now, as you know, we have tools for vitamin K antagonist monitoring, namely PTINR, which you are all very familiar with. It's the Neoptimal or Neoplastine product line. Our concern for today will be heparins monitoring and direct TNA monitoring, direct TNA inhibitors monitoring. For heparins, we have the unfractionated heparin, low molecular weight heparin, and fondaparinux. And for direct TNA inhibitors, the WAX, rivaroxaban, apixaban, and odoxaban. These are all monitored using the same exact kit, which is an anti-TNA or liquid anti-TNA kit. Finally, just as to cover it, we have also a kit that's used for monitoring the bigatran, direct thrombin inhibitor, which is called ECA2 or acarinic chromogenic assay 2. We will just glance over it very quickly, just for your information, but the focus will be on the anti-TNA range. Now, for a start, APTT versus antitin A for unfractionated heparin monitoring. Why would we change from something that is, we are very experienced with, we have been using it for a long time, and then move into antitin A, knowing that, of course, one of the first things that come to mind is antitin A is more expensive. It's a new kit, it's a new reagent. Why should I bother and move away from APTT for this purpose? This is what I will cover in the next few slides. So for a beginning, where did APTT start being used for unfractionated heparin monitoring? In the beginning, there was a method that was advised. So basically it is if your APTT is between 1.5 to 2.5, the baseline in terms of clotting time, let's say, then this was considered as some sort of a therapeutic range. This is the range where you should be on unfractionated heparin. However, this is a very old methodology, plus it was done in animals and was not basically validated on humans in randomized trials. So it's not really recommended. Later on came what is called in vitro heparin curve, as you can see here. So basically we have our pooled normal plasma where we add to it unfractionated heparin. Then we will measure the antitin A activity and we correlate it with the APTT activity for the antitin A therapeutic range, as you see, 0.3 to 0.7 IU per ml antitin A. Again, this was not recommended. It has a lot of shortcomings. So most recently, we have the ex vivo heparin curve, where we basically take samples from patients who are taking unfractionated heparin, we quantify their antitin A response, and we correlate it with the APTT. However, ex vivo heparin curve, even though it's the most recent, it's being used, it has a lot of shortcomings, and that is largely due to APTT itself and the many interferences which occur with the APTT test. So when I'm doing the ex vivo heparin curve, again, we said I will just correlate the antitin A therapeutic range, 0.3 to 0.7, with the response of the APTT reagent. Now, as you can see, this is called the Brill-Edwards curve. I'm sure you are very familiar with it. This is what you would use to establish the APTT versus the antiton A for unfractionated heparin. As you can see, APTT response correlates quite poorly with antiton A. So, for example, some people might be actually within the therapeutic range for antiton A, but APTT might show that this patient may be supratherapeutic or subtherapeutic. So, APTT tells you something completely different from the antiton A. And this occurs in so many cases, not just one case out of 1,000 or two cases out of 1,000. It's quite common. And the reason is, of course, as you know, APTT has a lot of interferences, factor levels, lupus, you have anti-factor antibodies, you have pre-analytical issues, etc., as you will see in the next slide. So here's a summary of the things which basically interfere with the APTT but have no effect on antiton A. So APTT, you have the pre-analytical part where the tube type, that's an interfering factor. The sample volume, if it's, for example, underfilled because of the higher concentration of citrate, that's a problem. Analytical issues such as lupus, for example, such an increased level of factor VIII, increased concentration of fibrinogen. Also, if the patient is taking other medications which can affect APTT, such as comedine, which is quite commonly taken, as you know. However, almost none of these, except for antithrombin deficiency, which is, again, it's a rare thing, really affect antitin A. So you can say it's a very robust test that's not affected by all these factors. And it's quite a big problem sometimes if I have a test that I really need to rely on to monitor unfractionated heparin, but it has so many interferences, which raises a lot of questions about is my result valid or no, which the antitin A is taking out as a variable factor. Last point that's worth mentioning. The therapeutic range for APTT has to be established at least annually using the Brill-Edwards graph. However, for antitin A, this is not really the case. So you will not have to go through this annual headache of re-establishing your APTT versus antitin A range. Now, on the side of the patient outcomes, as you can see, orange represents patients monitored with antitin A, blue represents patients monitored with APTT for unfractionated heparin. In the case of the incidence rate for bleeding, patients monitored with antitin A, at least in this study, have shown 4 times less bleeding incidence when antitin A was used to monitor unfractionated heparin. In the case of recurrence of thromboembolism, also still patients showed, even though it might not be huge difference, but still patients showed less recurrence of thromboembolism when antitin A was used as opposed to APTT. On the side of cost, however, which is, I understand it will be an issue for many labs. Okay, but the antitin A is more expensive. Why should I switch to it from APTT? It's significantly more expensive. Now, if you consider the number of tests done for each patient in terms of APTT versus antitin A, the number of dosage adjustments when you use antitin A or APTT, the reagent cost, of course, antitin A is more expensive, that's understandable. When we consider the lab technician, the phlebotomy labor, and the nurse labor, then some studies actually found that antitin A might be equivalent, if not slightly cheaper overall for the hospital to run as compared to using APTT for UFH monitoring. So yes, antitin A might be more expensive as a test per se, just on the lab level, but overall it might be actually equivalent, maybe slightly more expensive, maybe slightly less expensive. But the thing is also when you consider the interferences, when you consider all the issues that come with APTT, then you slowly start to realize that antitin A might be actually better in so many ways, not just the financial part. Now, moving on to the product itself. We will talk first about the antitin A in terms of heparins monitoring. So this kit actually comes first in a liquid format, so this makes it very easy to use for the lab. There is less variability from technician to technician. Of course, in terms of preparation, there is no preparation of reagent. It really is just ready to use liquid reagent. So this removes all this variability from user to user. It's a kit that is stable for 7 days on board on the analyzer and up to 3 total months at 2 to 8 Celsius, reducing your wastage quite significantly. And when there is any urgent samples, you don't have to start a preparation from scratch. The kit is ready for you to use there. This kit can be used for heparins, unfractionated heparin, low molecular weight heparin, fondaparinux. Then we'll go later on for the DOACs. So the same kit for all of them. You don't have to have a kit for unfractionated heparin, another kit for low molecular weight heparin. No, it's all the same. The reliability aspect, I will come to it in the next couple of slides. And finally, a small point, we have two formats of this kit. One that comes with 4 ml vials, another that comes in 8 ml vials if the lab has a really high workload. Now, about reliability, there are 2 points which I think are quite significant that need to be mentioned. So many kits in the market, a lot of them, especially for at least the major players in the market, a lot of the kits for antitin A activity, they contain something that's called dextran sulfate. Now, what is dextran sulfate and why is it significant in this context? Dextran sulfate is very similar in its charge to heparin. So what happens? Dextran sulfate is actually found in many kits other than Stago's kit, and it's found in a proficiency testing materials, the materials themselves. I will explain why is that. So what happens in vivo dextran sulfate in the patient body? Dextran sulfate is not really there. It's not found in the patient body. It's there in the antitin A reagent. So what happens? I collect the patient sample, I run it on the analyzer. Dextran sulfate is added with the reagent itself. It's part of the reagent. What dextran sulfate does is the following. It basically displaces heparin from all the proteins that it's bound to in the plasma, except for antithrombin. So as you know, unfractionated heparin, especially less so for low molecular weight heparin, they bind to proteins other than antithrombin, and they can bind to cell surfaces in the body. So this means not all the heparin is just bound to antithrombin. Now, when I take this patient sample and run it on my analyzer, a lot of the heparin that's not bound to antithrombin is actually released. It becomes free because dextran sulfate replaces it. What this means is this freed heparin, this newly freed heparin, comes to bind to the antithrombin in my sample, increasing the apparent antitin A activity in the measured sample. So this means that in vitro, when I actually measure the antitin A activity, it does not really reflect what happens in vivo, but rather I will have an overestimated antitin A activity for the patient, which is definitely not something that we want. Many studies have actually shown that reagents that contain dextran sulfate in the reagent itself, they tend to overestimate the antitin A activity in the patient sample. As you can see, for example, here, so this study have shown that when the reagent actually contains dextran sulfate, as you can see, positive DS, so the squares here or here, these are samples measured with a reagent that contains dextran sulfate. As compared to other reagents, the circles and the triangles here, they do not contain dextran sulfate. So the squares, which is a reagent that contains dextran sulfate, they tend to overestimate unfractionated heparin, and in some cases, low molecular weight heparin, which of course is not something that you would desire. Another point that's also important. A lot of reagents in the market contain antithrombin as part of the reagent, whereas Stago does not have that. Stago antitin A reagent does not contain antithrombin. The antithrombin that basically exerts the antitin A effect in the assay comes from the patient blood. So what's the importance of this point? Now, as you know, antithrombin levels, of course, they will vary from a person to person. And antithrombin is what exerts the antitin A effect when we are running this assay. So if I add antithrombin as part of the kit, we are more or less standardizing the amount of antithrombin in the assay when I run it on the analyzer. This means that the antithrombin, when it varies from patient to patient, of course, in vivo, I will not have the same amount of antitin A response. So basically, I'm nullifying this variation of antitin A response from patient to patient. What does that do? If the kit contains antithrombin as part of the reagents, then this means in some cases I'll be overestimating the antitin A response that's actually available in the patient blood, especially if the patient has antithrombin deficiency. That's especially true for antithrombin deficiency patients. Some studies actually found that when these two variables are combined, the antithrombin presence in the reagents and the dextrosulfane presence in the reagent. Then the most reproducible kits are the ones that contain no antithrombin and no dextran sulfate, which is the case of the antitin A kit from Stago. So this means that we will give you the best results possible, at least based on these evaluations, which are not just done by Stago. There is white papers from Stago, but according to many other studies. And few kits in the market at this point contain no antithrombin and no dextran sulfate at the same time. Before moving on from this slide, I mentioned to you that I will tell you why there is dextran sulfate in the reagents or in the proficiency testing materials. For proficiency testing materials, the manufacturers add dextran sulfate to reduce the variability between the reagents that contain or do not contain dextran sulfate, because they understand that there is these differences between manufacturers in the antitin A kits. Then why do the manufacturers of the antitin A kits add dextran sulfate? The reason is this will help in cases where platelet factor 4 is released in the plasma of the patient. Dextran sulfate will basically reduce the effect of platelet factor 4, which neutralizes heparin in the sample, making it look like it's lower than what it is actually in vivo. However, this backfires in many cases, as I have just explained. And there's a lot of evidence to support that. It's not just evidence from Stago. There's a lot of literature to support what is mentioned here. Now, for the product itself, we have calibrators for unfractionated heparin, low molecular weight heparin, and fondaparinux. One important point in this regard, we can have a single calibration curve. We call it a hybrid calibration curve for unfractionated heparin and low molecular weight heparin. So I receive a sample in the lab. I want to run it. Regardless, is the patient taking unfractionated heparin, low molecular weight heparin? I don't know at this stage. I can run just one single assay on the analyzer. I don't need to run on the UFH curve and the low molecular weight heparin curve. Just one curve for both of them. Then I release the result as it is. For fondaparinux, we have a dedicated or a separate calibrator. For the QCs, we have a QC dedicated for each of these types of heparins. Now, in this slide, I will just mention something that you probably already know. The therapeutic range for unfractionated heparin is 0.3 to 0.7 usually. Low molecular weight heparin around 0.5 to around 1.2. Now, why am I mentioning this here? I'm just mentioning this point to show you that the working range of this antitin A kit, which for the hybrid curve is 0.1 to 2.0, actually covers the therapeutic ranges for both unfractionated heparin and low molecular weight heparin. So you should not have any issues with the working range of the kit. Now, small point about the QCs. The QCs are stable around 4 hours on board, but the important point is that they are stable around 7 days at 2 to 8 Celsius, which means you don't have to reconstitute a kit every single day, or you have to reconstitute a vial every single day. You just reconstitute it, it's stable in your fridge for 7 days of use, reducing, of course, wastage, reducing cost, and making things more convenient for you to run, especially when you have urgent requests. You don't have to reconstitute the reagent, the QCs, all of it is ready there. For fondaparinux, just quickly over this point, fondaparinux, or what's known as Rextra, the commercial name, it's used for DVT in patients undergoing surgeries such as total knee replacement or total hip replacement. It's used also for DVT or acute PE treatment when it is administered along with warfarin. Another point is fondaparinux was shown to have a higher effectiveness in preventing VTE compared to low molecular weight heparin, and there is 2 randomized controlled trials to show this. Now, again, mentioning the fondaparinux. Now, fondaparinux, as you know, is given as fixed doses. At specific doses, I expect when I measure fondaparinux in my sample to recover the results within a certain range. So, for example, for this dose, 2.5 milligrams, I expect the drug levels to be around 0.2 to 0.4 micrograms. For this dose, 7.5 milligrams, I expect to recover a fondaparinux concentration of 0.5 to 1.5. Again, the reason I'm mentioning this is to show you that the working range for fondaparinux is 0.1 to 2.0 micrograms, which covers basically your needs for patient monitoring. Quickly again for the controls, the stability at 2 to 8 Celsius is 7 days. So it really is stable. You will not have any issues with having to reconstitute every single time and wasting your QCs. Dr. Muhammad, you wanted to say something?
No, no, late. Carry on.
Okay, thank you. Now, for DOACs, I will go over a quick overview. So DOACs, or direct oral anticoagulants, they are basically two types, or they target two activated factors. We have the anti-10A inhibitors, or direct factor 10A inhibitors, which include rivaroxaban. In black, this is the generic name. These are the commercial names in orange. So we have rivaroxaban, we have apixaban, we have adoxaban, and we have bitrixaban, which is actually discontinued for commercial purposes, so we will not cover that part. All of these, they are direct inhibitors of 10A, or factor 10A. Finally, we have the bigatran, which is a thrombin inhibitors. The commercial name is Pradaxa, but we will not cover the bigatran much. This is about anti-10A. DOACs are used for many indications. This is just a quick glance over these. So, for example, you have rivaroxaban used for major orthopedic surgeries, again, such as total knee replacement or total hip replacement. It can be used also for stroke prevention in cases of atrial fibrillation, and so on and so on and so on. Each of these is evaluated in the different clinical trials, and it's used for different indications. This is just for your information, of course. Now, the important part is, one of the major advantages of low molecular weight heparin, fondaparinux, and especially DOACs is that they more or less remove the need for monitoring. Unlike unfractionated heparin, you have to keep monitoring every once in a while. Then why would I need a kit that actually measures DOACs? DOACs, it's indeed true that yes, monitoring is way less than it is the case for unfractionated heparin. However, there are still cases where we would want to know this DOAC level in the patient's blood. For example, if the patient is going for a surgery and they have taken this medication in the last 24 hours, or in case they have creatinine clearance below a certain limit, which means that the body is not able to get rid of this DOAC as expected. Also, we want to identify if the patient is in a sub or supratherapeutic levels, especially for cases where the patient is taking medications which can interfere or are known to interfere with DOACs, or if the patient is at very high body weight, or if the patient cannot really clear this medication well, that is the DOAC, when they have problems with their renal system. Another point is when there is a reversal of anticoagulation that is desired, or when we are suspecting overdose. Or finally, we want to assess the compliance of the patient in taking this drug. If the patient is experiencing thrombosis or bleeding when they are taking this drug. Now, away from the clinical part, more onto the analytical part. DOACs are known to interfere with some clotting assays, especially when we talk about the specialty assays. But we will elucidate a little more about this point. DOACs also can interfere with chromogenic assays that use the 10A factor or the thrombin or factor 2A, because of course they are inhibitors of factor 10A and factor 2A, so they're expected to do that. In terms of immunoassays, such as, for example, D-dimer, then there is no reported interference of DOACs into these assays. Now, DOACs, again, can interfere with coagulation assays. And of course, our main concern will be, do these DOACs interfere with my PT, PTT, fibrinogen, thrombin, for example? For PT and PTT, DOACs, including direct inhibitors and direct thrombin inhibitors, they are not known to reliably prolong PT and APTT, especially at lower doses. So even if the patient is taking any of the direct inhibitors or the bigatran, they may or may not have a prolongation in the PT or PTT. So I cannot really reliably use PT and PTT to screen if this patient is in a DOAC or no. Okay, so they are not really useful. They are not really used in any capacity to quantify these drugs or screen for them. Of course, for measurement of the bigatran, we have again the carinic chromogenic assay. For the rest, the direct 10 inhibitors, we have the anti-10 kit, which are chromogenic assays. Now again, On the product side itself, for DOACs, we have a calibrator and a QC dedicated for each of these drugs. So we have a calibrator QC for rivaroxaban, for apixaban, and for edoxaban. Each of them is a separate kit. Now, for DOACs, we don't really have a therapeutic range as we do for unfractionated heparin, for example. We have something that's called an on-therapy range. We have a peak on-therapy range, and we have a trough on-therapy range. What do I mean with a peak on-therapy range and a trough on-therapy range? So a peak on-therapy range is the range of a drug that I expect in the patient blood when I collect their samples, for example, for edoxaban, after 1 to 2 hours of taking the drug. The peak on therapy range is the range of a drug I expect in the patient blood. For example, apixaban and rivaroxaban, when I collect the sample after 2 to 4 hours. Trough on therapy range is the same thing. However, the collection time for the sample will be before taking the next dose for this particular patient. So, for example, peak on therapy range for apixaban at a certain dose will be 30 to 153 nanogram per ml. At a higher dose will be this much. At even a higher dose, it will be this much. Of course, for every drug, it depends on the dose given for this drug. For the trough, for example, for apixaban, at a specific dose, I will have this much trough on therapy range. I will have this much at a higher dose on therapy trough range. So what I'm trying to say here is all these ranges fall within the working range of the anti-10A kit that we offer. So you will not really have any problem in monitoring your patients, whether they are in the peak on therapy range or the trough on therapy range. As you can see, the working ranges for all of these kits are listed here, and they are well within and covering all the on therapy ranges for all of these three drugs. Another point that's worth mentioning is LCMS, or liquid chromatography mass spectrometry, is the gold standard for DOAC measurement. And as you can see, our anti-10A kit correlates quite well with this gold standard. So you will have very reliable results from this anti-10A kit. Again, this is just a point about the calibrator, which we mentioned. It's regarding the working range. This is covered. Finally, for the controls, again, you will have very good stability at 2 to 8 Celsius. 7 days for rivaroxaban, 7 days for apixaban, and 6 days for edoxaban. So again, you will not have any issues with having to reconstitute every day, wasting your kit that you just used it once over that day. So QCs also are very good in that part. And that's it. Thank you very much for your time. If you have any questions, please let me know. I elected not to give too much details because I understand maybe your time is limited. So if you have any questions, please go ahead. I will stop the recording at this point.